Normally people, when I recommend them injection, they are scared. They are not scared of surgery, they are not scared of anything in medicine, but the needle, somehow there is a fear of needle. So the purpose of injection is not to completely bring you to a normal position before this accident happened, or before this disc herniated, or before something strong happened to your low back. The purpose is only to give you a break from pain so that we can do something about or around it. So remember, it's not the end but the means to another end. So a window of pain relief, that is what we are looking. Sometimes the back pain is so overwhelming. You have tried simple things, a medication, anti-inflammatory medication. You have taken some rest. You have done some physical therapy, but still the pain is significant and it is interfering with your function. Remember, when it is interfering with your function and has not responded adequately to the oral medication or physical therapy, this is the time for an injection. Normally people, when I recommend them injection, they are scared. They are not scared of surgery, they are not scared of anything in medicine, but the needle, somehow there is a fear of needle which they grabbed when they were younger. Because somehow in the early ages you go for vaccination, you go for any blood test, and the needle is what is now programmed into your body. So there is a fear of needle. Even those people who are very healthy, very big, very strong, army, marine, but they are afraid of needles. So that's okay, that's normal, because it is programmed from you from the childhood. But if I have to give you a needle for your back, you don't have to worry much about it. Now naturally, nobody can give you a guarantee of any procedure that this will go 100% right and it will make you 100% right. This is over-claiming, overrating the injection. The purpose of injection is to give you a break in the pain. Because your nerves are continuously firing for pain, they become more efficient. That means they are carrying the pain with minimum energy of their own. So what you are doing, you are breaking that pain cycle, because pain causes more pain. So the purpose of injection is not to completely bring you to a normal position before this accident happened, or before this disc herniated, or before something strong happened to your low back. The purpose is only to give you a break from pain so that we can do something about or around it. So remember, it's not the end but the means to another end. So a window of pain relief, that is what we are looking. How long this window? Sometimes the inflammation needs just a little bit of steroids and the inflammatory process is gone, and you can now strengthen the muscles around it. Sometimes you have to do more than one. So how we do this injection? This is called epidural injection. When you look at the spine, the front is the disc and the back is the joint, and in the center is the nerve root. So if the problem is coming from the disc or from the nerve root, then epidural injection could be a very significant and effective in breaking this pain cycle. The approach, actually there are three approaches for injection in the low back. One is called caudal epidural injection, which is done through a hole in the lowest part of the spine where the tailbone meets the sacral part, the pelvic part of the spine, and there is a natural hole which is roofed by a ligament. So there is skin, subcutaneous tissue and that ligament, and then there is a hole. We call it sacrococcygeal hiatus, or the hole. So once your needle crosses that hole, this is in epidural space, because the epidural space starts from the neck all the way to the tailbone, while the thecal sac, which is a fluid-filled sac around the nervous tissue in the spine, ends as S2. That means there is enough space where there is no thecal sac No nerves are coming out of the spinal cord or the lower part of the spine, and there is an empty space there. Once you put the needle there, the medication is going to go up in front of the thecal sac, in the back of the thecal sac, and on the sides of the thecal sac. That's why in a caudal epidural injection, the amount of fluid we put is quite significant. 5 to 8 cc of lidocaine, which is most of the time 1%, similar amount of normal saline, another 8 to 10 cc. So it makes the lidocaine little diluted, and 1 to 2 cc of Kenalog or triamcinolone or any other steroid. So the purpose is that the fluid is going to bathe the nerve root, going through the epidural space, decrease the inflammation, and give you a break from that continuous pain that is interfering with your function. So this is one approach. We call it caudal epidural injection. The second approach is called translaminar approach, which is directly from the back at a higher level where the pain is, where the disc is herniating, close to that translaminar. Now in translaminar, there is a chance that the needle tip can get into the thecal sac, where the fluid around the nervous tissue. If that happens, nothing big is going to happen, but you may feel severe headache and you might feel a little dizziness, because the medication is directly now going in the thecal sac. The idea is if you feel that, the doctor should not inject there. Similarly, the third approach is transforaminal approach, which is on the side of the spine. There are keyholes through which the nerves which are exiting the spine exit from that foramen. So between the foramen and when they are just exiting the nervous tissue, they have to go through epidural space. Now this is technically little more challenging because the fluoroscope or the specialized X-ray machine has to be exact when you put the needle, because your needle tip is very close to the nerves and it can even touch the nerve, which will be very painful. And since you are not fully sleeping, you can let the doctor know that you are feeling pain going down in your legs. But most of the time, even you feel something when it's going, because the doctor moves the needle very in small increments, and seeing the needle in the safe place just below the pedicle or just above the vertebral end plate. So there is a safe area. In either case, you can avoid getting into a vessel or into a nerve. And once you put that contrast, the contrast can flow in the epidural space and along the nerve root. And here you don't need a big fluid, you need a small fluid. So 3 approaches: the caudal, the interlaminar, and transforaminal. Out of these 3 approaches, transforaminal approach has very strong result, very effective result. However, when the pain is coming from multiple area, it's not possible to go to different areas. So the caudal approach is the first approach, and then later on, whatever is left, you can use a transforaminal approach. I use very rarely a translaminar approach because it is not found to be very effective. So the transforaminal approach is the best approach. So don't be scared of the needles, because every time I put a needle, I make sure that there is the locally skin is numbed, even if you are sleeping or you have moderate sedation or not. Either way, it is a painless procedure. The only time you feel some pain when we are doing, not pain, but actually pressure, heaviness on the back when we are injecting through caudal approach, because it's a fluid, big fluid going into a tiny potential space, and that space is very sensitized. So you might feel heaviness on your back, but the moment you stop, that heaviness goes away. So this will help us break the pain cycle and now really work on your muscles, which are the main modifiable elements in terms of relieving your back pain.